Welcome to ANA Investigates, a monthly podcast featuring the latest in neurology and neuroscience, brought to you by the American Neurological Association. I'm your host, Adeline Goss. Dysautonomia is a diagnostic and therapeutic challenge for many clinicians. The autonomic nerves reach every organ in the body, but their dysfunction can be challenging to detect and measure. As a result, patients suffering from autonomic dysfunction may endure long stretches without a diagnosis, presenting not only to neurologists, but also to cardiologists, gastroenterologists, and others. Fortunately, this area of neurology has seen major advances in recent years. Joining us today to help us understand the evaluation of autonomic dysfunction is Dr. Safwan Jaradeh. Dr. Jaradeh is professor of neurology, psychiatry, and behavioral sciences and director of the Autonomic Disorders Program at the Stanford Neuroscience Health Center. Dr. Jaradeh was interviewed by Dr. Richie from the University of California, San Francisco. Here's Megan.
Welcome, Dr. Jaradeh. Thank you so much for joining us on ANA Investigates to talk about the evaluation and management of autonomic disorders.
Thank you very much for the invitation. I appreciate it. Thank you.
So, Dr. Jaradeh, I'd like to start by asking you to briefly describe the scope of neurologic conditions associated with autonomic symptoms.
Yes. So the neurologic conditions that are associated with autonomic symptoms can be divided either based on symptomatology versus etiologic condition. So in terms of symptoms or syndromic presentation, the major autonomic presentation is usually in the form of various syndromes of orthostatic intolerance. A major one is variety of functional gastrointestinal disorders. A third major category is alterations in the body sweating and temperature regulation. A fourth category is genitourinary symptoms. So that will include a variety of bladder emptying things, as well as sexual disturbances. Sleep abnormalities are very common and can be an early presentation in a variety of autonomic disorders or dysautonomias. And finally, the autonomic nervous system has a central nervous component and a peripheral nervous component. So when the peripheral nervous component is affected, you sometimes get impairment in the sensory fiber function, the motor fiber function, or both, in addition to the autonomic function. So in terms of etiology, peripheral neuropathies, for instance, can be presenting with autonomic symptomatology that are dominant. On the other hand, a large category or central nervous system disorders that present with dysautonomia are degenerative disorders, usually in the family of Parkinson's disease. So I hope that gave the listeners an overview of the conditions associated with autonomic symptoms.
Yes, thank you for that detailed summary. So, what are the best ways to clinically determine that a patient has autonomic dysfunction?
So, I think one of the best ways to determine if somebody has an autonomic dysfunction is to do a very careful review of systems in the patient. So, like I said, a major source of referral usually, or a reason for the referral in these patients, is some type of orthostatic intolerance. So we start by asking the patient, do you feel lightheaded? Is it related to position? Some patients who have had this problem more chronically, they will feel probably more like they have weakness. They feel weak if they are standing up and walking around for a while. That can be a symptom that they have orthostatic intolerance. Sometimes also they feel that they have a heavy cape on their neck and shoulders, so they have this discomfort in that area, and it tends to be orthostatic. And a small subset of patients presents with imbalance that is orthostatic. So, they will tell you, I'm not really feeling dizzy, but the longer I walk, for instance, or the longer I'm standing, the more I feel like I'm drunk or imbalanced. So that can be also a potential red flag that you may be dealing with an orthostatic problem. Other symptoms that could happen and just reflect the decreased perfusion to the central nervous system will include things like slurred speech, brain fog, and transient confusion. These sometimes symptoms patients bring up. And when the patient brings those up, before we leave the subject, we often, in the autonomic practice, we try to figure out what else aggravates the problem. So, for instance, do they get worse after they eat a large meal, particularly if there is, some alcohol involved, they had a glass of wine with it. Outside heat, if they walk out in the heat and it's 100 degrees or 105 degrees Fahrenheit, Do they become more symptomatic? So that's the first big category. Then we usually, follow the other symptoms based on what the patient is coming to see us for. So if they have GI or gastrointestinal symptoms, we start first, asking them, do they have frequent nausea, early satiety? Do they have dumping syndrome? Do they eat and then they have to rush to the bathroom? In terms of genitourinary symptoms, we ask about urgency, incontinence. We ask about, sexual performance. And then we go to sweating. We ask, do they sweat excessively? Do they have dry skin? Can they sweat when they go out in the heat? And we also ask about secretomotor function in the eyes and the mucosa. So do they have dry eyes? Do they have dry mouth? And we ask about sleep. And then we ask about their balance and if they have abnormal movements. So after we take the history, finally we proceed to the exam. And there are certain things that are very good to look for. We always get orthostatic vital signs on the patients. And you record to see what happens to the blood pressure, the heart rate, as well as the oximetry. And changes can sometimes give you a quick idea that there is definitely a hemodynamic problem. And then I would do the detailed exam. But one of the things I look for is the pupillary function. Does the pupil react briskly to light? Does it dilate as well? And do they have the so-called tonic pupils? So as you have them accommodate on the light and then take it off and the pupil dilates slowly. So that can be an autonomic symptom. One of the things we look for, particularly in a person who's older presenting with dysautonomia, is we are looking for early extrapyramidal signs. Then we do, of course, the reflexes. And with the idea and the reflexes, you want to know, is there, for instance, distal areflexia? And then we do the sensory exam. And finally, we look for the Babinski sign. We do the cerebellar exam. And then we have them do the gait and watch the gait. And if you are still suspecting a degenerative extrapyramidal disorder, then of course you need to do the postural testing and testing them in antipulsion and retropulsion. We also look for changes in the extremities. If they have vasomotor pooling in the feet and in the legs, are they turning purple or red? And then if they lay down, does it improve? That can be a sign of vasomotor autonomic impairment as well. So these are really the key things we look for in the exam.
What an illustrative reminder of the rich information that a neurologic history and exam can provide. Thank you. So, what more advanced testing is available to evaluate autonomic disorders?
So in terms of testing that is specific for the autonomic disorder, there are standardized tests that we administer to the patient. So if somebody presents obviously with orthostatic intolerance, which is the most common presentation in the autonomic clinic, then we do the so-called autonomic cardiovascular testing. And that usually consists of three major maneuvers. The first maneuver is measuring the heart rate variability to deep breathing. So we have the patient take deep inspiration and expiration, and normally there is a respective increase in the heart rate and decrease in the heart rate. And we average, 5 to 6 cycles, and we do the test at least twice for the purpose of consistency. And we see how much of an average of heart rate variability they get. And that's a very, very good test, particularly for cardiovascular parasympathetic function. The second test we do is the so-called Valsalva maneuver. So we give the patient a mouthpiece and we have them usually blow in it as if they are inflating a balloon. And we have a set pressure that they go to, usually 30 millimeter of mercury. And they have to hold it for about 20 seconds. Traditionally, while the patient is blowing, there is a decrease in the blood pressure and increase in the heart rate. And once they completely release the blowing or the pressure, there is actually the reverse. They have an increase in the blood pressure and decrease in the heart rate. So the ratio between the high heart rate while they are blowing and low heart rate after they are done blowing is known as the Valsalva ratio. And that usually depends on the parasympathetic portion of the baroreflex. And then the magnitude of the drop in the blood pressure during blowing and how well it recovers to baseline, and then versus blood pressure overshoot after they are done blowing, the so-called overshoot in phase 4, is a very good index for vasomotor adrenergic or sympathetic hypofunction. So patients who have adrenergic problems causing their orthostatic intolerance, they often will drop their blood pressure significantly, and they cannot recover very well by the end of the blowing maneuver. So that's the Valsalva maneuver. And then obviously the tilt table testing is key in these patients. And in neurology, the tilt table test is a little bit different from cardiology. Our cardiology colleague usually do the tilt for 20 minutes, then they do pharmacologic triggering, if you will, or stress by giving either nitroglycerin or isoproterenol, because they are trying to induce syncope. In the neurologic autonomic clinic, we are really trying to see what the profile of orthostatic intolerance is. Is it an immediate transient orthostatic hypotension? Is it more of a delayed orthostatic hypotension? And of course, sometimes patients will faint, but the purpose of the testing is really not to induce syncope. So in general, in neurologic autonomic centers, we do not give pharmacologic challenge. What we do, though, is that we do other provocative techniques. So mental stress is one of them. Hand grip we do. And then a small percentage of patients describe their syncope as really somewhat atypical. They have something that looks like maybe it could be a partial complex event. And so we have a protocol here at Stanford where we get a baseline EEG on them before tilt, and then we do it with tilt and trigger maneuver. So that's the cardiovascular part. The second part is the so-called sweat testing. And sweat testing, the most common one that's done in autonomic centers is a so-called quantitative sweat test response. And in that particular test, we put a small capsule, plastic cup, over the patient's foot, distal leg and proximal leg near the thigh. And then we do one on the forearm. And then we put in the capsule acetylcholine, which is the neurotransmitter to the sweat gland. And then we pass a very, very small current. It feels like a small sting or burn. And we pass the current, and then that iontophoresis the acetylcholine, which then stimulate the unmyelinated C fibers, which innervate the sweat gland, and that secrete sweats, and you collect it. And that gives you really a waveform that looks like a nerve conduction waveform, except it's from an unmyelinated fiber. Finally, the final test, and that's not as widely available, is basically the so-called thermoregulatory sweat test. The patient will wear a disposable swimming trunk. We dust them with a powder that has a special marker. In our case, it's yellow-orange. And then we have them lay in the sauna, standardized temperature and humidity. And as they sweat, basically, the sweat changes the color to purple. And you get basically a map of their sweat. And finally, depending on the cases, occasionally we proceed to a fat aspirate biopsy if you suspect that the patient may have amyloid, or we sometimes do skin punch biopsy to diagnose the density of epidermal nerve fibers, the sweat gland density of innervation, and if you are suspecting a degenerative disorder, to do for synuclein staining.
Thank you so much for this very thorough overview of how to approach patients with autonomic dysfunction. So I'd like to take a moment and focus on one condition in particular, postural orthostatic tachycardia syndrome, or POTS. This syndrome has been an illness of some previous historical controversy, with certain providers even questioning whether it exists. So if you don't mind, please summarize the latest understanding of this disease.
Yes, so POTS is a condition where there is a mismatch between the hemodynamic demands of the body during postural changes and the heart rate that's needed to fulfill or meet those hemodynamic demands. So in these patients, when they stand up, there is an inappropriate or exaggerated increase in the heart rate, defined as in excess of 30 beats per minute in adults and 40 beats per minute in the pediatric population. And this exaggerated increase produces the orthostatic symptoms that these patients have, which actually, for the most part, seem to resemble orthostatic hypotension. The understanding of POTS is that it is due to a component of cardiovascular deconditioning. Sometimes it's induced, for instance, by an illness. There is also a component of relative hypovolemia. If you do plasma volume measurements in these patients, it's very common to see relative hypovolemia. And in a good percentage of patients, there is an increase in the cardiovascular sympathetic or adrenergic sensitivity. And this particular subset of patients, or the so-called hyperadrenergic POTS, are sometimes mistaken for psychiatric diagnosis. Physicians think that they have just anxiety and somatization because of all the symptoms. And one way actually to diagnose this condition is not only by doing the autonomic cardiovascular tilt testing, which confirms a pretty significant increase in their heart rate during tilt, but also you can also get a baseline supine norepinephrine. And then if you have them stand up or tilt them and do the blood test after that, there is usually 3-fold or greater increase in the amount of norepinephrine, while in a normal person without dysautonomia, the increase is usually 1.7 to 2 times in terms of norepinephrine. So that suggests that they have marked increase in their adrenergic sensitivity. And it's really no surprise that these patients will describe anxiety. They will have increase in their physiologic tremor. They will appear very nervous, but it's because they have an organic increase in their adrenergic tone, leading to their symptomatology, not because they have a psychiatric disorder.
Excellent. Thank you. So, what strategies do you recommend for treatment of patients who have refractory orthostatic intolerance?
So in terms of refractory orthostatic intolerance, first you want to decide, is it postural tachycardia or is it hypotension? And actually turned out some strategies are common to both. So first, we start with the so-called counter maneuver or non-pharmacologic measures. So that will include things like elastic stockings. Abdominal binders are very good. They are useful in POTS, but they tend to be more useful in refractory orthostatic hypotension. The second arm of the treatment will be volume expansion for depletion conditions. So in POTS, there is a relative hypovolemia, and we usually recommend the patient that they ingest at least 3 liters of fluid per day, preferably up to 4 liters. And then they need to increase their sodium. The minimum they could take is 6 grams. Preferably, they should have about 8 grams. So that usually helps POTS, but also helps orthostatic hypotension. And finally, we use pharmacologic measures. So in orthostatic hypotension, we tend to give a low dose of a mineralocorticoid, something known as fludrocortisone, that expands the plasma volume. It also works in some patients with POTS as well. The other medication we use is a vasoconstrictor, the so-called alpha agonist. The most commonly prescribed one is midodrine. Some patients actually respond to pyridostigmine, which enhances the ganglionic transmission. It uses acetylcholine. Patients with neurogenic orthostatic hypotension, where there is a mismatch between how much the heart rate increases versus the blood pressure, seem to respond to pyridostigmine, which has also the advantage of not producing supine hypertension at night. There are new drugs coming down the pipe, but there is a drug that has been FDA approved. It's called droxidopa. The drug basically gets converted to noradrenaline. It can also be used in some patients who either have difficulty tolerating the pharmacy I mentioned, or if they do not respond to it. A catch with these medications is that, as you increase the dose, you can get into the dilemma of having a supine hypertension. So you have to balance the two quite significantly. But that's basically the strategy for orthostatic hypotension and POTS.
So, Dr. Jaradeh, I was wondering what work remains to be done in the field of autonomic disorders. What would be your call to action for ANA members?
Thank you. Thank you for this important question. I think there is a big need to improve the genomics and genetics of these disorders. Some patients have, for instance, genetic disorders involving the norepinephrine transporter. So we need to understand how this works a little bit better. There is bigger need for drug studies, development for instance, neurogenic orthostatic hypotension or refractory orthostatic hypotension that does not respond to the measures I've mentioned a couple of questions earlier. And finally, I think looking at prospectively at therapies that could also prevent or block the progression of a degenerative autonomic disorder. I mean, now, for instance, we can do skin biopsies, look at the fiber density, we can look to see if there is synuclein accumulation. It will be good to figure out what treatment could potentially blunt or slow down the progression of this process. So that I think is my view and my call to action to our wonderful colleagues and members.
Dr. Jaradeh, thank you so much. It has been an absolute pleasure to talk with you.
Thank you, Dr. Richie. And I also want to thank the American Neurologic Association for giving me this opportunity. It's been a pleasure and a privilege to talk to you and other colleagues. Thank you very much.
That was Dr. Safwan Jaradeh, director of the Autonomic Disorders Program at the Stanford Neuroscience Health Center, interviewed by Dr. Megan Richie, associate professor of neurology at UCSF. You can find past episodes of ANA Investigates and pitch an idea for a future podcast at myana.org. For ANA Investigates, I'm Adeline Goss.
This has been an episode of ANA Investigates, the official podcast of the American Neurological Association, and an ANA Education Innovation Subcommittee production. Thanks for joining us. To learn more about today's program and to find out about the benefits available to ANA members, including access to an array of educational programs and resources, please visit myana.org. Dr. Adeline Goss is our host and the executive producer of the show. Episode producers are members of the ANA Education Innovation Subcommittee, chaired by Drs. Megan Richie and Romer Giaccaden. This is your logistics coordinator, Jen Hurley. Copyright, the American Neurological Association.